Can you see?
Yes, sir. Yes, sir.
Okay. So I'll just put it on the presentation mode. All right. So let us start the discussion on PPHN, that is persistent pulmonary hypertension of newborn. And as rightly pointed out, it is nothing but it is a nightmare for the neurologist who is attending the child. So let us start with the case. Now, this is a baby born to a gravida 3 mother, para 1, L1, and A1 at 38.1 weeks of gestation. She had previous LSCS, and this time they had to go for emergency LSCS because she had a thin scar and meconium stent like her, and on NST, they were late decelerations. And we knew that this child has expected fetal, where the expected fetal weight of this is around 2.8 kilos. So when the baby was born, baby didn't cry immediately after birth. Heart rate was less than 60, iNOs, meconium stained. So child required intubation at birth for being non-vigorous, and bag and tube ventilation was given. So by the time we completed the resuscitation, these were the Apgars. Apgar at 1 minute is 5, 6, and 8 at 5 and 10 minutes respectively. And the heart rate was 100 per minute at the end of resuscitation. SATs were still around 50 to 60%. Baby was shifted to NICU bag and tube ventilation. The child was put on SIMV mode of ventilation with 60% FiO2 to begin with. The rates were adjusted to 40, pressures of 20 by 5, MAP of around 10 to 11. And the first ABG when we draw, for the attending consultant rule, was pH of 7.213, CO2 of 64, oxygen of 33, bicarb of 5, and lactose of already 6, base excess minus 4. And when we calculate the OI, it was around 18. And the pre and post ductal SO2 difference was around 18, so 16 to 18 all the time. So in view of hypotension, a normal saline bolus was given, and dopamine was started initially at 5 mics per minute, and later on it was increased to 10 micrograms per kilo per minute. So with this history and the background, what we have, so what can we do more? Like, there is a recipe where the child had meconium stained amniotic fluid. The child was born limp, non-vigorous, child required resuscitation, child required intubation and ventilation. Initial SATs were pretty low, and subsequently child had to go on SIV mode of ventilation. And once the child settled a little bit, in view of hypotension, dopamine was started going up to 10 mics per kilo per minute. And the ABG showed severe respiratory as well as metabolic acidosis. This was the X-ray, which was done later, and it looked like typical, dirty lung appearance. You can see that, bilateral haziness, there is some areas of consolidation, etc. What is the probable diagnosis here? So if you look at the history, if you look at the setting, so we can very well, it is written all over the case or all over the patient that is a case where the child has meconium aspiration syndrome with probably persistent pulmonary hypertension of newborn, and child is in shock because child required bolus and child required inotropes to get the blood pressure up. So what is this PPHN? That is persistent pulmonary hypertension of newborn. So if you define it, we did the 2D echo, but I'll come to that later. And the patient was transferred to us with the diagnosis of persistent pulmonary hypertension of newborn at 8 hours of age. So what is this PPHN? PPHN is nothing, but it is a postnatal persistence of fetal circulation. So in simple terms, the fetal circulation as it existed in utero, it persisted even after birth, albeit without placenta. And what you see here, there is sustained elevation of pulmonary vascular resistance and the right to left shunt at the ductus arteriosus or foramen level, foramen oval, in the absence of structural heart disease. I think this is very, very important. The heart is structurally normal, but there is, along with that, there is increased or elevated pulmonary vascular resistance with right to left shunt happening at either one or both the places. So to understand what is fetal PPHN, we need to understand what is the fetal circulation like. So let us go back to our basics, what we learned. As you can see this in picture, in utero, the lungs and the alveoli are filled with fluid. So they are not taking active part in the respiration. And what happens? The pulmonary vasculature, it is constricted because that is how the interior or the milieu is like that. And then when you enter environment is like that, with that, there is no need of pulmonary blood flow, and that's why it is a constricted pulmonary vasculature, and the alveoli are filled with the fluid. Now, towards the maternal side, what happens? The maternal uterine artery, it supplies blood to the intravillar space. So this is basically your placenta. And from the placental villi, the oxygenated blood goes through umbilical vein and it joins the IVC, and it follows the selective path on the lateral wall of the IVC, and it enters selectively or preferentially into the left side of the heart, from left atria to the left ventricle. And then from the left ventricle, it supplies predominantly the brain. So brain receives the upper half of the body receives the more saturated blood. And subsequently, this blood, when it comes to the descending aorta, it is joined by the ductus arteriosus blood, and it is with lesser saturation as compared to the blood here, and it supplies the rest of the body. So what happens? The blood which is supplied to which is in the systemic circulation through IVC, it comes up, it joins the oxygenated blood here, but it preferentially follows on the other side of the wall, and it enters the right side of the heart. And through pulmonary artery, it enters again DA. Now, what happens? Some of the blood which goes to the pulmonary artery enters the pulmonary circulation, and it comes back here on the left side, but it is only hardly 15 to 20%. The majority, 80% of the blood through the ductus arteriosus joins aorta. All right, so this is typical fetal circulation. So two important shunts are operate here. One is at the foramen oval level, that is PFO, we call that, and second at the ductus arteriosus level. So these two shunts are very, very important in utero survival. What happens at the time of birth? That is the cardiorespiratory adaptations which happen at the time of birth. One is the most important event which happens is the aeration of the lungs. So what happens here? The replacement of the lung fluid by air. And it is very, very important. And it happens because the first breath, which happens due to high opening pressures and active expiration. So this is the first breath which replaces, which aerates the lungs, which expands the lungs. The sedation of the lung fluid is happens, the lung fluid production. So again, that helps in clearing the fluid. Remaining fluid gets absorbed into the lymphatics and circulation. And lastly, during the squeeze, very minimal amounts get squeezed to the second stage of the labor. So basically, the fluid which is in the lungs and which is in the alveoli is replaced by air. The second most important event which happens is the fall in pulmonary vascular resistance. And it is directly effect of aeration of the lungs. It will be mechanical effect as well as the reflex vasodilatation. So this vasodilatation helps in bringing the pulmonary vascular resistance. And mind you, the oxygen is the most potent pulmonary vasodilator. And when baby breathes even 21% oxygen, that also causes pulmonary vascular dilatation and drop in the pulmonary vascular resistance. There are endogenous mediators which again cause vasodilatation, and the net effect is the pulmonary vascular resistance or the pulmonary artery pressure, which is in the range of around 60 millimeters of mercury at the time of birth, it goes down to 30 millimeters of mercury immediately after birth or within 1 hour. And the subsequent reduction happens over a period of time. By 2 to 3 days, it is down to normal, that is around 5 to 6 millimeters of mercury. So this is the fall in pulmonary vascular resistance and pulmonary artery pressures after the baby is born. What next? The third important event, or the two events which happen, that is closure of the shunts. The two shunts, one is PDA, that is ductus arteriosus, and second one is foramen ovale. So clamped cord, and as the placenta is off the circulation, there is decreased venous return to the RA. That leads to fall in right atrial pressure. If you remember that figure, which we'll come back to that again, and that leads to fall in the right atrial pressure. But because of increased pulmonary blood flow, there is increase in the left atrial pressure, and leading to closure of the foramen ovale. Second one is the loss of umbilical venous return, decreased flow to ductus venosus and ductus venosus as well. And subsequently, same things happen leading to closure of the ductus arteriosus because increase in the systemic vascular resistance, systemic blood pressure, and fall in the pulmonary artery pressure. So go back to the basics again. The first figure where we saw that there are two shunts which are operating, one at the foramen ovale level, one at the ductus arteriosus level. And after birth, both the shunts, they close. And now what you see here is, instead of two parallel circulations going on the way it is going here, now everything comes in series. So from the right side of the heart, the blood goes to the lungs. From the lungs, it comes to the left side of the heart. Then it goes to the systemic circulation and like so on. So this becomes from parallel circulation to it goes into the circulation in series, and which is very, very important. What happens in PPHN? The transition which should be happening, where SVR should be on SVR, that is systemic vascular resistance, has to be higher than the PVR. And the flows, there shouldn't be flow at the PFO. And if at all, the shunt should be flowing from left to right in the ductus arteriosus. Everything is reversed. And what happens is there is a right to left shunt at the atrial level. There is right to left shunt at ductus level. And the right ventricle pressures are higher because the PVR is higher than the systemic vascular resistance. So this is where we go back to fetal circulation, and that is what we call as PPHN, that is persistent pulmonary hypertension of the newborn. So mind you, cardiorespiratory adaptation at birth is the most dramatic event in the human physiology. And as you see that all these things which we discussed just now, they happen in synchronization, and that's why most of the babies, after birth, they stabilize and they can go to the mother. But sometimes it doesn't happen. And why it doesn't happen? Because the most critical step in adaptation is the lowering of pulmonary vascular resistance. And if you come here, if the lowering doesn't happen, the lowering of PVR, then it leads to PPHN. So there are certain factors which increase pulmonary vascular resistance, and there are certain factors which decrease PVR. So let us look at the bad guys first, that is the factors which increase PVR. There are, of course, hypoxia, acidosis. Then there are inflammatory mediators like endothelin, leukotrienes, etc. Then, of course, if there is a vascular remodeling because of any particular reason, that can lead to increased PVR, pulmonary hyperplasia, congenital diaphragmatic hernia, pulmonary thromboembolic phenomena, or alveolar-capillary dysplasia. All these factors, they increase pulmonary vascular resistance and they cause PPHN. But at the same time, there are factors which counteract these effects. Mainly the oxygen. As I said, oxygen is the best pulmonary, the most potent pulmonary vasodilator. Then, of course, endogenously produced nitric oxide. There are other mediators which also help. Prostaglandins, they help in pulmonary vasodilatation. Of course, bit of alkalosis can help your properly expanded lungs reduce pulmonary vascular resistance. We have a nice graph which I can show you later. And there are certain vascular change, structural changes happen in the vasculature over a period of time that can also decrease pulmonary vascular resistance. So the transition from high resistance pulmonary circulation to low resistance pulmonary circulation and high resistance systemic circulation is very, very important. And we need to look at the factors which are operating at during that time. So what are those pathological mechanisms which lead to high PVR or PPHN? So we saw some of the mechanisms or some of the mediators, but now I will tell you which are the conditions which can lead to this kind of problem. One, which we see most of the time, there is maladaptation. So there is problem in the transition because of meconium aspiration syndrome, as we see in this child, or events like parental asphyxia, transient tachypnea of newborn, sepsis, pneumonia can release various inflammatory mediators. It can cause hypoxia itself and then lead to increased PVR and of course hypothermia. Then there are conditions because of maldevelopment, like if there is placental insufficiency, chronic placental insufficiency, premature closure of PDA. Many times it happens because of the medications use antenatal NSAIDs or aspirin. We don't see much here, but there are sometimes the drugs like which are used, like SSRIs, can lead to pulmonary hypertension. Now, the third condition where underdevelopment of the lungs in conditions like congenital diaphragmatic hernia or hypoplasia, if there is a space occupying lesion in the lung like CCAM, the huge CCAM, can again lead to underdevelopment of the lungs and ultimately reducing the surface area, that is pulmonary vasculature area, and thereby it leads to the increased PVR and pulmonary hypertension. Structural obstruction, mainly we see in patients with congenital heart defect. That is a typical example is obstructed TA PVC, and functional obstruction. Sometimes we do see in the NICU when the child has severe polycythemia. So I think these are the pathological conditions or the clinical states where we can come across pulmonary hypertension because of the various mechanisms operating that time. If you have to make it very simple, so this is a flow chart which you can remember. The very old flow chart published in 1984. Like first you think whether if the child has PPHN, so what is the arterial number? There is pulmonary arterial vasculature area or the number, whether it is normal or it is decreased. So if it is decreased, then definitely lung hypoplasia and conditions like CDH, space occupying lesion, CCAM, etc. If the number is normal, then you look at what happens. It is because of the abnormal vascularization. Abnormal vascularization happens due to developmental immaturity or the chronic conditions like vascular remodeling, which happens in idiopathic or primary pulmonary hypertension of the pneumonia, or if there are any malformations, like auricular capillary dysplasia, you will have increased muscularization and leading to PPHN. If there is if the muscularization is normal, then it could be because of the developmental immaturity or maladaptation, which we normally see in conditions like sepsis or meconium aspiration syndrome. Whatever the reasons are, whatever the pathological condition is, what is a common final pathway? That is increase in pulmonary vascular resistance because of pulmonary vasoconstriction, and the causes could be many. This leads to decreased pulmonary blood flow, which in turn will lead to acidosis, hypoxia. This will again increase PVR and leading to right to left shunting. And this process will go on in a vicious circle and the child will deteriorate. So we talked about the fetal circulation. We talked about the what are the conditions which can lead to increased PVR and PPHN, and what is the mechanisms of the pathways which can lead to, or the factors which contribute to the development of PPHN. Now come to the diagnosis. The diagnosis is pretty simple. It starts with high index of suspicion. So we need to look at which are the conditions or which are the perinatal situations we can come across, or which are the high risk states. One is IUGR babies, or the babies who are post-mature or post-term babies. Babies born through meconium stain amniotic fluid, like in our case. The presence of congenital diaphragmatic hernia detected antenatally. Presence of lung formations, again detected antenatally. History of consumption of NSAIDs during pregnancy. As I said, history of drug abuse or med, something like SSRIs, known for pulmonary hypertension. And of course, if you have diagnosed a congenital heart disease like with like PAPVC or left-sided obstructive lesions. When I say left-sided obstructive lesions, you can think of it could be TAPVC. Starting from TAPVC, it could be because of the obstruction at the pulmonary artery level, or it could be obstruction at the pulmonary valves. It could be obstruction, even the RV dysfunctions. All these factors can lead to problem. Anything which increases your pulmonary vascular resistance to the backflow mechanism, all are included in that. So look for the clinical settings, especially the perinatal factors. Then comes the clinical settings in the neonatal period after birth. That is meconium aspiration syndrome, perinatal asphyxia, the babies with severe hyaline membrane disease and TT and can have pulmonary hypertension, significant pneumonia, sepsis, especially child with sepsis and septic shock. Don't forget pulmonary hypertension. It can coexist. And if the child has CDH or CCAM, if the child is hypothermic or receiving hypothermia therapy, or if there are any conditions, clinical conditions like polycythemia. Now, this is underestimated, but the babies who are significantly polycythemic can have PPHN. And what the treatment here, you don't have to do anything else, but just take care of polycythemia, either by partial exchange or liberal IV fluid therapy. The child will get better. How to diagnose? As I said, very simple. Look at the perinatal setting, and look for the high risk factors. And once the baby is born, if there is persistent hypoxia or cyanosis in spite of high supplemental oxygen, with in the presence of respiratory distress and tachypnea to the tune of 80 to 100 per minute. And when you do the chest X-ray, you can see existing lung disease if there is CDS, if there is meconium aspiration syndrome or pneumonia. But sometimes if the child has primary pulmonary hypertension, you may find the lungs absolutely normal. Okay, and many times you can see that other system examination is normal, because the mainly here the pathology is restricted to pulmonary vasculature in the form of increased PVR. But however, if in a child with perinatal asphyxia or CDH, you can see other organ systems affected. So what is the hallmark of the disease? Labile hypoxia and cyanosis, disproportionate to the degree of parenchymal disease, is the hallmark of pulmonary hypertension. How to diagnose? As I said, we look at the clinical setting. We look at the child who has tachypnea, who has got respiratory distress, significant hypoxia, not responding to high supplemental oxygen. And if you look at the cardiovascular finding, child will have tachycardia, loud and single second heart sound. And you can appreciate, if you listen carefully to auscultate these babies carefully. Soft systolic murmur, and usually this murmur is of tricuspid regurgitation. You can see precordial impulse many times, and there is a pre and post ductal oxygen gradient to the sometimes in to the tune of 20 millimeters of mercury. Many times these babies present with hypertension. You must be wondering if the problem is with the pulmonary vascular resistance or the pulmonary blood flow. So why is hypertension? Very simple answer. There is decreased pulmonary forward blood flow that leads to the decreased left ventricular preload, and therefore the cardiac output will be left ventricular output will be low and the cardiac output will be low and hypotension. Second thing is the bulging septum into the left ventricle, and that will itself will lead to reduced left ventricular end diastolic volume, and it will cause problem. And many times these babies with PPHN have associated LV dysfunction. So these babies can have significant hypotension, which should be taken care of when we are treating these babies. If the child has central cyanosis or the cyanosis which is not responding to the oxygen supplementation, we have been told and taught about hyperoxia and hyperventilation test. If the child fails hyperoxia and hyperventilation test, then we should really look at whether we are dealing with critical congenital heart disease. If the child improves after hyperventilation, probably we prove the diagnosis of pulmonary hypertension. But mind you, when you do hyperventilation, you need to be very careful. One is you have to really hyperventilate the child at 100 breaths per minute and with 100% oxygen, and you have to do it for 15 minutes. And once you do that, you have to do the ABG and you have to look at change in the PO. Okay, so this is what you need to do. You should conduct this hyperventilation test. So other modalities we can check, we can do the X-ray. Usually heart size is normal. Sometimes we'll see, if it is a parenchymal lung disease, we'll see signs of meconium, signs of HMD or pneumonia. And if there's a defect like diaphragmatic hernia, which will be obvious, ECG, of course, we'll see right-sided abnormality in the form of right axis deviation, signs of right ventricular hypertrophy, and signs of RA enlargement. These are some of the X-rays you can come across. Of course, this is different stages of iron membrane disease, like this one here. It is severe HMD. Now, this is a child who has whether they're the grade 3, grade 4 HMD, and here we can see the one with the child with meconium aspiration syndrome, and of course the CDH. But these are the typical findings you come across many times, or many times you may not see anything on the parenchymal parenchyma. What is the gold standard? So all this, the investigations or the clinical setting, they help you to diagnose. But ultimately, the gold standard is 2D echo. And when you do the 2D echo in these babies, the most important thing when you diagnose or before you diagnose PPHN, make sure you are excluding critical congenital heart disease. Extremely important. And many times we came across babies were diagnosed with PPHN. Most of the time these 2D echoes were done by adult echocardiographer because they are the only available in those areas. And when the child comes to us, we found that the child has TAPVC. So this is one of the commonest diagnosis of CHD which we can miss or miss in diagnose as PPHN. We need to document the shunting at the right to left shunting at either duct or PFO level. If it is PPHN, definitely we need to assess the degree of PPHN based on your TR jets. And of course, when you are doing the echo, assess the atrial size, ventricular size, and function. One more important message here, the pure right to left shunt at PDA level in a structurally normal heart almost confirms the diagnosis of PPHN. So if you see this, more or less, you're confirming the diagnosis of PPHN if there is if the heart is structurally normal. So let us look at the echocardiographic features of PPHN. As I said, structurally the heart should be normal. There is right to left shunting at the level of PFO and ductal level. Dilated RA, dilated RV with dysfunction. The flat or bowed IVS to the left, interventricular septum to the left. I'll show you the pictures later. You can see presence of TR, very important. It will help you in assessing the degree of pulmonary hypertension. Suprasystemic PA pressures. Again, this is a hallmark of PPHN. And once you have these findings, while doing echo, if you start nitric oxide in these babies, what you can see that there is significant, you can literally see decreased pulmonary arterial pressure, increased pulmonary blood flow, and your TR jet comes down. And this is what you will see dramatic response when you start nitric oxide in a case which has been diagnosed with PPHN. how can you assess this PA pressures or the pressures in the pulmonary artery? As I said, you can just eyeball once when you're doing the 2D echo. If there's right to left shunt, if there's PDA or PFO, dilated RV, and flat interventricular septum or going to the left side, it tells you that there is increased pressures on the right side, increased pressure in the right ventricle, increased pressures in the pulmonary vasculature. If you want to do the objective measurement, the best way to do it is look at the TR jet velocity. So I'll show you some of the 2D echo images. Now this is the apical four-chamber view, and I don't know whether this will work. Okay, it's not working, but what you see here is basically there is significant dilatation of the right ventricle, and our intraventricular septum is almost flat, as you can see here. And yes, your RA is a little bit dilated, but it is a little bit foreshortened view. I'll show you one more better image probably after this. Yeah, now this is the baby which we're talking about, maternal vascular syndrome. And ventricle settings were increasing, and the child had hypertension as a patient. Now this is what we are seeing. Apical four-chamber view. This is dilated RA, this is dilated RV. And of course, you can see the septum, which is flat. When we put the Doppler gate here, what you can see here, the red flow, which you are seeing, is the forward flow from RA to RV, and the blue jet, which you are seeing going back into the RA, that is your tricuspid regurgitation jet. And this is what one should measure. And when you measure it, so when you measure the jet here, what is going to happen? As you can see, this is the velocity, that is around 4 meters per second. And if you put into this velocity into modified Bernoulli's equation, that is pressure gradient across RA and RV, this is the equation, that is 4V square. And if you put these values in that, what you get is the pressure gradient of 64 millimeters of mercury. Now, mind you, this is a pressure gradient. We have to add to this the pressures in the RA. So if you say that RA pressures are around 5 to 6, even if you add that, your right ventricular pressure becomes around 70. So your pulmonary arterial pressure is almost 70, 71. So which is a suprasystolic, the suprasystolic or suprasystemic pulmonary artery pressures. So this is what I was talking about. When your RV pressures are increased, see, this is the normal configuration. When you look at the normal heart, RV is like banana shape or crescent shape, and this is your LV. The moment RV pressures start increasing, the RV dilates, and it pushes the intraventricular septum into the left side of the towards left side. And as you can see, it has become flattened, and your LV becomes D-shaped. Okay, so this is a classical compressed D-shaped left ventricle when you say in severe pulmonary hypertension. This is what you see when I take the image. This is short axis view, and you can see that the interventricular septum is flat, and your left ventricle is typically D-shaped. So you can, there are some pros and cons when it comes to you measure the TRZ. One is, it is not always present, not necessarily. If there is significant RV dysfunction for some reason, you will not see you won't be able to properly estimate your TRZ and thereby the pulmonary artery pressures. And here we have to assume the RA pressure. So we took the number of 5 to 6 and we add to that. So maybe the RA pressure may be more, or maybe RA pressure lesser than what we have assumed. We can measure the PA pressures even looking at the ductus or the gradient across the patent ductus arteriosus. So this is your three-legged view where you have RPA, then we have got left pulmonary artery, and this is the aorta, the descending aorta, and this is your patent ductus arteriosus. So again here, by measuring the gradient across duct, you can measure the pulmonary arterial pressure. So this is the duct, as you can see, and you measure the gradient across it, which is the left, proper right to left shunting happening here. And when you measure this, similarly, what we did previously with the TR jet, you look at the velocity, which is 1.6. You put it in the modified Bernoulli equation of 4V square, you get the PA gradient around 10.9, and then you add to the pressures, that is systolic blood pressure is around 48 here. So we add 48 to that, what number we get is around 58.9. Again, the pressure, PA pressures are around 58 or 60 again, suprasystem. So what are the cardinal features of PPHN? One is severe hypoxemia with pre-ductal and post-ductal difference of at least, and what you see is in the PO2 is less than 50 millimeters in 100% of FiO2. Labile hypoxemia disproportionate to clinical and radiological abnormality. I think this I mentioned before as well. Clinical evidence of right to left shunt at different levels and structurally normal heart. So these are the classical cardinal features of PPHN, and what you see, I described some of the echo features when you look in PPHN, and all those features aid in the diagnosis of PPHN. So once you have diagnosed PPHN clinically, once you have confirmed the diagnosis by doing 2D echo, what is next? Here the nightmare starts. The most important thing is if you don't have the facility or the capacity or the infrastructure to look after this child, the child needs to be transferred to the tertiary care center, who can offer this care. So earlier you transport to a higher center, better outcome. So don't waste your time, and the child should reach the right place at the right time in a right manner. Okay, so the safe transport is also equally important in these patients. If you can manage this patient, what are the issues you are facing here? Basically, high pulmonary vascular resistance, low systolic blood pressure or systemic blood pressure, and leading to low cardiac output, and presence of parenchymal disease. What are the goals here? One is reversal of hypoxemia. You have to increase the oxygenation. How you're going to do it? By lowering the pulmonary vascular resistance, optimizing the ventilation by proper lung recruitment, using adequate positive and expiratory pressure, to maintain the cardiac output and blood pressure. Again, this is very, very important. Reversal of right to left shunting. So if you increase your systolic blood pressure, if you increase your SVR, maybe we can reverse the shunting at ductal level and even at the PFO level. Improve arterial O2 saturation and O2 delivery to the tissue. So both the things are important. One is improve the saturation, you have to improve your ventilation, and improve your oxygen delivery to the tissues, you have to improve your cardiac output. So both the things you need to look at. So both, it's just, you have to take care of both heart as well as the lungs. While doing all these things, make sure you're not damaging the lungs or causing minimal lung injury as much as possible. When we are doing, our focus is on lungs, our focus is on heart, don't forget the general management. And rather, I would say that, one should be doing the general nursing of these patients very meticulously. And if you do that, half battle is won. And what is that general management? One is this baby should be continuously monitored for oxygenation, blood pressure, perfusion, all those parameters. These babies should be minimally disturbed, very minimal stimulation. Adequate sedation and analgesia is very, very important. Again, I say this: adequate sedation and analgesia. Whether you must relax them or not, It depends on the clinical situation, but adequate sedation and analgesia is very, very important. Avoid excess noise, excessive light, handling, and rather I call it as a PPHN corner. So if you come to my NICU, what we see there is a corner which is relatively quiet, relatively darker. There is no noise at all. The nurse who is looking after the child will be handling the child only when it is required. No chest physiotherapy on this baby. If you're going to do any procedures, try to club them together and do only when mandatory. Like, these babies don't require protocolized suction. Do suction only when it is required. Correct all the metabolic abnormalities. Which are those abnormalities you come across? If it is abnormal pH, you correct the pH, correct the acidosis. If it is hypocalcemia, take care of calcium. Glucose, hypoglycemia is very, very important. So you need to tackle that. So you need to make sure the sugars are maintained. Maintain thermoneutral environment. Hypothermia increases the pulmonary vascular resistance, but hyperthermia increases your metabolic activity, heart rate, etc. Correct polycythemia. As I said, I think if the PPHN is because of polycythemia, you have to fix polycythemia first, and the rest of the things will fall in place. Or at least you maintain, if it is polycythemia, you try to correct and target PCV around 45 to 55. Take care of fluid and electrolytes properly. Maintain calcium, magnesium, sodium, potassium at the normal levels. Now coming to the ventilation. If you are ventilating the child, what are the goals of mechanical ventilation? First and foremost, you have to restore functional respiratory capacity. Basically, you have to expand the lungs. If there is a parenchymal lung disease, that's what we should do. And even if you're dealing with meconial aspiration syndrome, like in our case, restoring FRC is paramount importance. How you do that? You can use conventional ventilation or high frequency ventilation. You can use lung recruitment strategies like optimizing PEEP. I think the PEEP is very, very important. I'll come to that. I'll show you the very good graph. You can use surfactant therapy. If it is HMD and even in meconium aspiration syndrome, you can open the lungs. And this is what I was talking about. The people are scared to use positive and expiratory pressure, thinking that it will affect the lungs badly, it will cause air leaks, it will affect your hemodynamics also. But this graph shows the relationship between positive and expiratory pressure and functional respiratory capacity, and how it affects your PVR, that is pulmonary vascular resistance. See, on your y-axis, there is pulmonary vascular resistance. On the x-axis, the lung volume or PEEP. Now, look at this line, which is thick line, and this represents your alveolar vessels. Okay, now this dotted line, this is a red dotted line, represents your alveolar vessels, and blue dotted line represents your extra-alveolar vessels. So now this is 0, and this is as the lung volume increases. So let us start with extra-alveolar vessels. When the lungs are collapsed, like here, your alveolar vessels are they are collapsed as well, and the PVR is high, as you can see here. As the lungs expand, the extra-alveolar vessels dilate and PVR comes down, and the lungs volumes are very good. Your extra-alveolar vessel PVR is very, very minimum. Now coming to alveolar vessel, this is a red dotted line. When the lung volumes are less or the lungs are collapsed, your PVR is minimum. But as the lung starts expanding or the lung volume starts increasing, you can see that the vascular resistance in alveolar vessels increases. So they are going in the opposite directions. So where is the optimum lung volume? Where in both the vessels, the PVR, the vascular resistance is less. So this is that sweet point. So this is the point where you need to expand the lungs. This is the point where you need to bring the FRC. And this is the point you should set your PEEP. So at this PEEP level, your FRC will be optimum and your pulmonary vascular resistance will be minimum. So this is does any ventilator give you this number? No. So how you do that? Basically trial and error. Make sure that lungs are adequately expanded. You can look at your the saturations, you can look your hemodynamics. Once you reach this level, your ventilatory parameters are at the minimum level. Your oxygen requirement will be minimal. If you put the PV loop, your lungs will be ventilating at this the straight portion of the PV curve, and your hemodynamics will be better. So this is what I was talking about. Once you achieve that FRC or adequate PEEP, you'll be ventilating in this area, and this is the area which the lungs like, and this is the area where the minimum lung injury happens. When you're the ventilating, the targets are PO2 is around 80 to 100 millimeters of mercury, CO2 around 35 to 45, and pH is around 7.2 to 7.4. So this is very, very important. Many times, the people tend to hyperventilate. They try to maintain the oxygen levels above 100. It is not beneficial. If you cause hyperoxia, what is going to happen? Definitely is not going to benefit in terms of pulmonary vascular resistance. It will induce formation of free radicals. And second, the third thing, it will suppress the endogenous production of nitric oxide. So all these problems will happen if you cause hyperoxia. And of course, it is bad to the lungs, it is bad to other organ systems as well. What about hyperventilation? And when you bring the CO2s down or below 30, what is going to happen? When you do that, of course, you are hyperventilating, and by hyperventilating, you are causing damage to the lungs themselves. And second thing, again, you can cause injury to the brain, because hypocarbia can cause cerebral vessel constriction, and it will decrease cerebral oxygen delivery. So I think we have to keep this in mind and avoid both hyperoxia as well as hyperventilation. So our ventilation target should be something like this. High frequency ventilation, yes, it can play a good role here, because it is supposed to cause lesser barotrauma or volutrauma, effective alveolar ventilation, and it can lead to better alveolar recruitment. And many times, if you use high frequency ventilation with nitric oxide together, it is more effective. And the studies have shown that there is some decreased need for ECMO if you are using high frequency ventilation, but it has to be used at the right time. Of course, these are the couple of studies which have mentioned here. It helps in oxygenation and carbon dioxide elimination if you use high frequency ventilation. But what they found that there was no significant difference in the mortality. At 28 days, there was no difference in the days on ventilator, oxygen therapy, or hospital stay. Now coming to the other important aspect of PPHN management, that is hemodynamic support. What is the goal here? Basically, when we say hemodynamic support, you're optimizing the cardiac output to maximize tissue oxygenation. So whether it is shock, whether it is respiratory failure, whether it is anything, the most important when the child is sick, the main aim is to optimize tissue oxygenation. And in PPHN, how will you do it? By increasing systemic vascular resistance to eliminate right to left shunt and decreasing the pulmonary vascular resistance. So how you increase SVR here? Basically, you have to target the systolic blood pressure of 50 to 75 with a map about 45 to 55 millimeters of mercury, so that it is above your pulmonary artery pressures. If you have the baby required, don't hesitate to give volume and expand the preload or intravascular volume with normal saline. Use vasopressors. It is very important, but they need to be used judiciously. So if you want to use vasopressors, if you want to use inotropes, you need to know the mechanism of action. See, the drugs like epinephrine, they cause even dobutamine, they have chronotropic effect. They increase the heart rate. Epinephrine has inotropic effect. At the same time, in higher dosage, it can cause increases systemic vascular resistance. Noradrenaline, it is purely, most of the time, it raises systemic vascular resistance, though it has got some inotropic effect. but the good thing is it doesn't cause tachycardia. Vasopressin, it is pure vasopressor. It doesn't have any effect on the heart. And rather, vasopressin has a dual effect. It increases SVR, and at the same time, it brings your pulmonary vascular resistance down. So you need to know all these inotropes and vasopressors properly, and you have to use judiciously. You can't have one fixed combination. Okay, I use only epinephrine. I will use epinephrine plus milrinone or etc. I think you need to use them judiciously, and you can use it intelligently if you know them. What are the pulmonary vasodilators? There are many, but one of the thing which we use, which is both iNO dilator, it has which has got inotropic effect, it has got systemic vasodilatation effect, that is milrinone, it has got some effect on the pulmonary vascular resistance also. Are there any specific pulmonary vasodilators or selective pulmonary vasodilators which decrease pulmonary vascular resistance selectively? And I think we know one which we use very often in most of the units, that is inhaled nitric oxide. There are some more, I think I'll come to that later. So why iNO or inhaled nitric oxide is ideal when it comes to pulmonary vasodilatation? One is it is, once administered, it is rapidly inactivated by hemoglobin because of the ultra short half-life. It's a selective pulmonary vasodilator. Once it goes, it reaches the pulmonary vasculature, it helps in dilating the pulmonary vessel. It is not affected by the extrapulmonary shunts which are there. By opening the pulmonary vasculature, it improves VQ mismatch. Not affected by endothelial cell injury or dysfunction, and it doesn't cause systemic hypertension. So I think this is one of the important advantage when it comes to nitric oxide. So it's a selective pulmonary vasodilator, and it doesn't have any effect on the systemic blood pressure. What is the dose and duration? The most important thing before you start, or when you start thinking about use of nitric oxide, make sure your lungs are expanded properly and there is optimum alveolar requirement, so that your nitric oxide which you are delivering, it reaches all the alveoli. And if it reaches alveoli, or it reaches maximum number of alveoli, it will reach the pulmonary vasculature and it will decrease the pulmonary vascular resistance. So when you consider, normally if OI starts going about 2022, you start considering nitric oxide. So nowadays we don't wait. If your OI is more than 15, 16, you start thinking of HFO. If the OI is more than 20, 22, you start thinking about nitric oxide. It can be given by conventional or HFO, high frequency ventilation. If when you start with the lower dose. I usually start with 5 ppm and then go up to 20 ppm, depending how the grade, and you see the response. Some people they to go up to 80 if the child doesn't respond, but majority of the times if the child is not responding at 20 ppm, less likely to respond even at 60 or 80 ppm. And as I said, when it is more effective or more better when it is used with other treatments like HFOV and surfactant, which cause recruitment, which improve FRC, which open up the lungs, and thereby it improves the delivery of nitric oxide. Usual duration is around 3 to 5 days, but when you start weaning or when you stop, what is going to happen? There is rebound hypoxemia can occur. So don't wean nitric oxide rapidly. Why it happens? Because when you rapidly wean nitric oxide, during nitric oxide therapy, endogenous nitric oxide synthesis is suppressed. And along with that, there is free radical oxygen radicals are there. They also suppress endogenous nitric oxide. So we have to give time for that. That's why wean nitric oxide slowly. And while weaning, you have to take help of something, sometimes sildenafil, so that you avoid the rebound phenomenon. If you give or at the higher dosages, it can lead to toxicity. It can lead to methemoglobinemia. Those levels should be maintained when the child is on nitric oxide level. So this is what I was talking about. This is a PPHN corner, relatively dark, white, without much disturbance, lesser handling, and take care of sedation, take care of analgesia, and treat all the other like hypothermia, hyperthermia aggressively, take care of your electrolytes, etc. Weaning of nitric oxide, as I said, it has to be done slowly. Once the FiO2 is down to 60% for more than 6 hours and your ventilatory settings are less, you start weaning nitric oxide, looking at your PO2 levels, wean 2 to 4 ppm at a time every 6 hours. And once you reach 5 ppm, you wean by 1 ppm every 2 hours. And I will leave sometimes, 1 ppm for even 4 to 6 hours before I completely stop it. FiO2 can be increased by 10% to prevent rebound hypoxemia, or even you can add sildenafil. What are the contraindications? These are the contraindications. If there's a lethal congenital malformation, there is no point in using, or if there's a irreversible lung pathology. If you've got clinical bleeding or platelets are less than 50,000, you can correct it and then you can use it. Again, if it is severe intraventricular hemorrhage, one shouldn't be using nitric oxide. Adverse effects we talked about, and toxicity also we discussed. Literature evidence, yes, iNO improves outcome. It reduces the need for ECMO. It improves oxygenation in almost 50% of the infant receiving nitric oxide. And HFOB plus nitric oxide is better an alternative than either alone. I think this is what I mentioned before. Sildenafil, again, this is poor man's nitric oxide. It is labeled as, but it is nothing like that. It can be used along with nitric oxide or while weaning nitric oxide. It basically acts through inhibition of 5-phosphodiesterase, and thereby it improves the causes vasodilatation. What is the concern here? Basically, systemic hypertension. Dose, if it is the IV, 0.4 milligram per kilo over 3 hours loading dose, and followed by continuous infusion at 1.6 milligram per kilo per day. If we are using enterally, and normally I do this when we are weaning nitric oxide, start at 0.5 milligram per kilo per dose, and titrating the response, you can go up to 2 milligram per kilo per dose and give every 6 to 12 hours. Can be used during weaning nitric oxide when iNO is not available and PPHN is refractory to nitric oxide. Mind you, one thing, the most important thing, when you are giving sildenafil, and if the lungs are not properly expanded, or if there is a collapsed lung, or this huge area of atelectasis, you might cause more desaturation, more cyanosis, because iNO acts on all the pulmonary vessels, irrespective whether that part of the lung is aerated or not. And that will increase your shunt fraction, and it will lead to cyanosis or decrease, even it will, or drop in saturations. A couple of new drugs, they are not new drugs, but they are drugs used in vasopressin, that is vasopressin, and this is the study which was published. Basically a case series, and what they found that when you use vasopressin in PPHN, it is effective because it reduces pulmonary vascular resistance to vasopressin receptors. At the same time, it increases systemic vascular resistance. So this one drug can do both the things, and which aid in improving oxygenation, at the same time decreasing the shunt at the ductal level. So this is a very promising drug. And there are many more, there are a couple of more trials which will be coming soon and will be published, which will definitely tell us how it is going to work. But I think vasopressin is very promising drug in PPHN. Another trial which has come up, that is MIN trial. And basically here they couldn't complete the trial because hardly any patients were recruited. There were only 4 patients allocated intervention and 5 to the placebo. But what they found that, there was no difference in both either primary outcomes or the secondary outcomes. So yes, the milrinone can be helpful, especially if you're dealing with a child who has severe pulmonary hypertension, and along with there is RV and LV dysfunction. So in the setting of dysfunction, milrinone can be used in PPHN. Other vasodilators, yes, prolazoline, adenosine. There are some there are some case reports. Even prostacyclin. This is used in idiopathic pulmonary hypertension as infusion, Okay, and these are the chronic the patients where it can be used. As I said, sedation analgesia is important in these patients. I keep on harping on this because any noxious stimuli will lead to catecholamine release, which increases PVR. So it will also can lead to patient ventilator asynchrony. So I think the sedation analgesia is very, very, very important. And I prefer to use either fentanyl or morphine if available. The other avoid benzodiazepines in this patient because already systemic blood pressure is on the lower side and they are negative inotropes, they are the benzodiazepines. So avoid them as much as possible. Surfactant therapy, yes, in patients like HMD or meconium aspiration syndrome to open the lungs to get the FRC, we should use surfactant. Alkalosis, strictly no, don't do that. No hyperventilation, no bicarb therapy. Muscle relaxants, use only when it is required. Newer and experimental therapies, I'm not going to talk about that. Bosentan is definitely being used. Again, this comes mainly used in the cardiac ICUs and in the chronic pulmonary hypertension patients. And there are some newer drugs like L-arginine, SOD, and etc. ECMO, yes, very important. This was the study which was done in 2000 or published in 2000. Study population of 185 term units. 62% had PPHN and they were severely hypoxic, up to 40. What they found that when ECMO was used in this babies, the mortality was 32% versus 60% in the conventional group. Very important finding. But then you can look at this. The study was published in 2000. Okay. This was before the widespread use of HO4V, nitric oxide, and surfactant. So probably if you do this study now, what you see is, as you can see here, use of ECMO has dramatically come down. So this is from 1990 to 2016. You can see the use of ECMO in pulmonary hypertension. So as use of HO4V increased, as inhaled nitric oxide became easily available, and similar units started using use of ECMO has dramatically come down. But if the patient doesn't respond to nitric oxide, doesn't respond to high frequency ventilation, then definitely one can consider ECMO in these babies. We talked about future promises. I'm not going to go into that details. Now coming to prognosis, yes, this diagnosis carries high mortality, but with use of HO4 nitric oxide, it has come down to significantly to around 10-15%, which can still, we can do better. These babies require high long-term follow-up because they are prone for high neurological morbidity later in life in the form of learning difficulties, motor neuron deficits. They can have visual and hearing difficulties or deficits. And sometimes they can get into chronic pulmonary hypertension. So one should be followed up regularly. Take-home messages. Hypoxia disproportionate to degree of clinical or radiological abnormality should arouse suspicion of PPHN. Labile oxygenation, difference between pre and post ductal saturations clinically point towards PPHN. It may be primary or secondary to diseases like MS, sepsis, ADH. Echocardiography is the gold standard for diagnosis. And make sure that the heart is structurally normal. Maintain normal milieu and good lung recruitment. Always consider early transfer to a tertiary unit if you are inadequately equipped to handle the case. Expertise, equipment, and infrastructure all are very, very important. Goals of therapy: reduce PVR, increase SVR. All these factors are important. Avoid factors which increase PVR, oxygen therapy, nitric oxide, vasodilator therapy. Lung protective ventilation is very, very important. And good nursing and supportive care is the mainstay of therapy. Don't ignore that. And this is the corner I was talking about, the PPHN corner. This is how it should be maintained. Thank you very much. I don't know whether I can take the questions. If there are any, you can post. Are there any questions? Hi,
I think, sir, there is no question, sir, till now.
okay. Hope everybody was awake.